This video is made for implant dentistry specialists. Warning: there are graphic images of surgical procedures, so viewers sensitive to blood and surgery need not view this video.
This presentation is going to be an update on what we call the custom Endosteal implant. Previously, 50 years ago, it was called the subperiosteal implant, but over a number of years, several of us around the world developed this implant further to make it fully integrate. And then we changed the name to the custom Endosteal implant because the histology we did in Japan and published many years ago, 10, 15 years ago, proves that this implant, once placed into a notched bone and covered with a grafting material, will completely integrate. Thus, we call it a custom Endosteal implant. I'm taking old videos and I'm updating because today we can do three-dimensional printing of titanium. So there's no longer a necessity to take an initial impression. The initial models and all that are taken off a CAT scan, a three-dimensional CAT scan, and then the design is made and then it's printed with three-dimensional titanium. So when I go through this, it'll just be the surgery of placement and the techniques that we've done over the years that make this implant very successful. And then in the end, I'll show you x-rays that show 30 to 35 years success rates of this implant modality. At this point, if I pass away, I'll be 80 in a few weeks, and I have the technology, but at my death, probably technology will be lost. So I'm doing this video for individuals who want to be updated on the technology and carry this forward.
Now this is our patient with the atrophic maxilla, and we're going to be doing an incision, keeping our blade as far to the buccal as we can to get the maximum amount and we carry it from one tuberosity to the other. We're going to do a midline relieving incision and then two buccal relieving incisions in the posterior. Flap and get the periosteum up and intact without ripping it all to threads. And this is important because this periosteum is our barrier that slides over the implant. And so if we can get this reflected in such a way that we preserve the periosteum, it'll benefit us in the osseous integration of this implant. Also, if you notice, I'm using the two elevators. I pit one against the other, and I find that by holding the flap up with one and using the other one to reflect the flap, that I get a much cleaner flap. And now as reflecting the palate, once you get the attached tissue from the height of the ridge, you move the elevator toward the bone, around the bone, keeping the tip on the bone, and then kind of ripping it away from the palatal bone. And this flap usually reflects quite readily. Okay, now as you're removing the tissue from the anterior nasal spine, this tissue is really tenaciously attached. It needs to be cleaned off very well all the way up to the top of the nasal spine. Now here, the sphenopalatine bundle, we're dissecting around it, and then you can see we just broke through it, and there's no bleeding there because I've never found an active blood vessel there in hundreds of these surgeries that I've done. You just cut through it and continue to flap until you get the whole palate flapped. Now we're tying back the tissue in the palate to get the tissue out of the way for placing the implant. And we just suture through the palatal tissue on several locations, and then we pull it together like a purse string, and it just pulls it together and out of the way so that we can continue with our procedure without the palatal tissue being in the way. So this is our transfer template that was made in the laboratory off the model. For the the notch to the exact time that we place the implant. That way the implant fits down into the notches like an inlay perfectly, and the part of the implant that's in the notches actually integrates to that part of the bone just exactly the same way as a root form implant. Now we're using a very narrow lab burr crosscut fissure, and it cuts through the bone very nicely. We keep water, copious amounts of water going on to the osteotomy, and you can see the bone just paints out of the transfer template. And we continue this until the bone is completely gone through the facet of the transfer template. And once that's done, then the implant will inlay perfectly into those notches. By notching the bone, you eliminate the possibility of bone loss underneath the crossover strut, and you ensure that the crossover strut and the abutment will integrate to that part of the implant, thus sealing it from invasion from bacteria once it's fully osseous integrated. The step takes a few minutes, and just make sure that you check to make sure that all the bone is gone from those facets in the transfer template. That way you don't have to carry the transfer template in and out of the mouth and take excess time. But this is a fairly easy procedure, and it's really easy to see, and the facets are so that you can tell exactly when all the bone is gone, because we want as tight a fit as we possibly can in this area. With a plasma taken from our PRP mixture, and this coats the implant. Now that the implant's been coated, we're going to take the anterior of the three sections for the maxilla and place it up into the grooves, and as you can see, it fits extremely precisely, and it fits like an inlay into that bone. Now we're going to screw the implant in with a titanium screw. These are self-tapping screws, and it takes 3 or 4 turns to get the tapping part of it going, and then the screw in, and then just cinch it down. Be very careful not to over tighten it, and that'll secure the implant. The next thing is to tap it to make sure that you have an integrated sound. Now we're going to put in the right side implant, and you can see the coating of the plasma on the implant. And as we slide this one in, this one really fits tight. So as I try to slide it in, the resistance form is so tight that I can't put it in by hand. So what I'll do is reach for my little hammer and my mallet, and then I'll tap that into place, as you'll see in another couple seconds. What I do is have the assistant hold it with one finger, and then I'll place a tapping tool over the abutment and then tap it straight in. Now we're moving over to the left side, and before we place the implant, we're going to be augmenting the underside of the sinus, and we use the same bone mix that we use for augmenting the implant itself by gently teasing it up into the sinus. And we're not going to place that much bone into the sinus because we really need only enough to cover the strut as the strut moves through the inferior portion of the sinus. Now we're placing the left side implant, and this one just goes in with finger pressure without any trouble. But you can see how beautifully it inlays and how close it fits. Now we're mixing our PRP with our 4060 HA, and then we add a little thrombin, and as you mix it, it clumps up the mixture and actually makes a really nice grouting mixture to grout into the implant. We're starting to grout this implant in. We've grouted a little bit on the right side, and we place enough grouting material to cover over the struts. On the buccal, where there's a lot of bone loss, you can grout even over the struts, or anywhere where the bone once was, we can grow bone. On the palatal side, we don't want to put quite as much. Flap, and we go to that posterior superior area where the periosteum is pinned to the bone where we ended our flap. So we just cut through the periosteum and make sure it gets released posteriorly. And once it is, then just follow the periosteum and cut just a millimeter or two into the periosteum, coming forward all the way anterior. And then the flap should be entirely released, and you can pull that down over the abutments if you want. It's so loose. Then we're going to take the palatal tissue and just compress it. We can see we got the flap right because the flap fits right behind the abutments. Now we're going to be doing the suturing, and we start out by pulling the midline together, the buccal flap, and we suture through the proximal end of both of those buccal flaps and then to the palate, and then pull it together like a purse string. And this photograph represents 1 week healing of the mandible, and you can see the tissue's already pink and healthy. This slide represents 3 weeks healing. This shows the maxilla. The mandible looks very much the same, but now the tissue is much more mature and there's no sign of any dehiscence, and the tissue is healed around these abutments extremely well. This is the post-op x-ray of the implants in place, and they all look very good, and these implants will integrate very nicely. Here's a photograph of the tissue after the crown and bridge has been placed, and you can see how pink and healthy that tissue looks around the implants. Healed around the mandibular teeth, and you can see the tissue is nice and pink and healthy and looks very good. Here's a patient's final white teeth. The patient wanted white teeth, and it's very hard to get really good characterization, but she liked this smile very, very much. This is the patient's final smile, and you can see the smile fits in her lower lip line, and she was very happy with the result.
The next section in this presentation will show a very important publication that we did, and what it does, it establishes a success rate of the custom Endosteal implant and a prediction of a success rate for each implant that you place. So you can confidently tell your patient that this implant has been tested over many years, and it was done in a sequential analysis way, which is an accepted way to determine how successful the next implant will be in a series. The case was published in Dentistry Today, and it was mainly to show that the custom Endosteal implant is a very sophisticated, up-to-date modality. It's not the old subperiosteal implant that sits on top of the bone and the gum is sitting over top of it, but it's a fully integrated implant. And what this article presents at the end is a sequential analysis of 5 retrieved implants. These patients were selected randomly as they agreed to participate in the study, and then their case was analyzed, retrieved at the time that they died, in order of each case that were in the study died, and we had 5 cases that are published. So we're going to go over that, and also the patient that's reported in this has an 18-year history of the custom Endosteal implant. She got her first one 18 years ago, and then 12 years later she came in for the upper custom Endosteal implant. This case went over a period of 18 years and shows how successful this implant was in 2 stages. This patient that's in the study, you can see on the x-ray here that there is no bone on the mandible or the maxilla. And the treatments 18 years ago started with just an implant on the mandible. But these poor patients can't get regular implants because there's no bone for it, and there's not even enough bone to graft. So this case is extremely important because at the end of it, we reported the sequential analysis of 5 cases that were retrieved from patients and then studied histology. So here are 2 panels, the before surgery panel, and then after the custom Endosteal implant, and this implant is for an overdenture, and it's basically in 3 sections, and it's connected with a bar system with O-rings. Here's the case on the left with the bar in place with the O-ring, and then the denture, the implant supported overdenture with the O-rings on the right. Here's this beautiful lady 18 years ago when we finished the lower, and she's been very happy. In fact, she's on my Facebook. We follow her on Facebook even to this day. The picture on the right is the denture and lower denture in place over the implant, and then you see how happy she is, and she's been happy all these years. So being successful for 12 years, her upper denture was getting to the point where she couldn't wear it anymore because the ridge had gotten so thin that the tissue became very floppy and she couldn't get any suction. So 12 years after we placed the lower in 2018, she comes in and requests an upper custom Endosteal implant. This represents a time in the history of the custom Endosteal implant where we really went full bore into high technology and 3-dimensional printing of our models, and then the 3-dimensional model would go to Montreal where they have supercomputers where all the design was done on the computer. And you can see on this photograph here with the post, all this stuff was done in virtual reality. And the x-ray represents how the upper and lower dentures with little round balls in it would orient the bite of the upper and lower model. And then the lower left shows the denture that was planned for this. And so the implant, which is the lower right, was designed to fit within that framework of the plan so that the implant would fit perfectly. The surgery is what we showed you in the first part of this video. It's exactly the same as it's been for many years. The implant is placed into notches that are cut through what we call a transfer template. And then once the implant in, it's screwed in, and then it's grafted, and then the tissue is released from the bone by cutting the periosteum and releasing the flap, and then suturing it so it's loose, and then waiting 6 weeks to start to finish the implant. The upper left shows the healing several weeks after the implant, and so the upper right shows using a CO2 laser to expose the finish lines on these implants. All these implant copings are all parallel to each other, and there's finish lines on each one. And the denture actually swedges onto this. The final denture swedges onto this, and there's no cement required for this particular denture. So here's the final appliance. The upper left shows the aesthetics. They're beautiful aesthetics for these cases, and the lower right shows the metal copings that are fused into the overdenture, and then the upper right shows the appliance in the mouth. And so here is the final smile of the patient, and we pride ourselves into doing very, very nice natural aesthetics. And this was 18 years after she had actually got her lower done, and this finishes up her upper. This slide demonstrates what it looked like when she came in for a follow-up about 6 months ago. On the left, we show the tissue, how healthy it is around these upper implants. And here she is, a little bit older now than she was before, but happy as she can be. And like I say, we're following her on Facebook. And I stayed in my practice for over 50 years to be able to follow these patients like this. And I've done hundreds and hundreds of these cases. And over the years, I've only had problems with less than 4 or 5, probably only lost 4 or 5 over since 1988, since we started doing this. And a few we've done minor revisions. But these patients, when they get this extensive dentistry for a dentist is in the same location and they know where he is at, if there's a problem, they find me. But fortunately, we found very few problems. And if we had a problem, then we would fix it. A few years ago, I had a case that Dr. Golick had done on a lower, and it was 35 years in service when she came in. And there was a lower screw in the anterior, and that got loose and caused a little drain. So we did a minor surgery, and off she went, 35 years later. But this implant seems to be, in my opinion, is one of the most successful implants in my practice. And it just goes year after year after year with very few or minor problems, and most with no problems whatsoever. So I highly recommend this. In the discussion, we added in and reported what we call a sequential analysis of the histology of the custom endosteal implants harvested from 5 deceased patients, what I talked about in the beginning. But the analysis was done by selecting the patients who were willing to sign up for permission for us to retrieve their implant upon the time of their death. These patients' loved one would contact us when their loved one died. We would go to the mortuary and retrieve the implants and then send them Dr. Lemon in Alabama for the histology. And all of these implants showed exactly the same osseous integration pattern, the same as we've been reporting in our lectures, that these implants, once placed and integrated and in for a period of time, will fully integrate. And we're able to show that with 5 cases. Here's the histology that Dr. Lemons did. And you can see from this blow up on the left side, it's a blow up from the right side histology and showing integration almost all the way around these struts. And it's what we found with all 5 cases, no matter where we looked at these struts, they were fully integrated. And over the years, they don't have problems because they don't have the accessibility to the outside environment because they're fully integrated like normal implants. So that's what allows the success rate, long-term success rate, that we've seen with this implant system. So to review the study, it shows a confidence level at a 90% success rate. The study was over a 5-year period, but the cases were selected for histology in a sequential way. The patients were selected as in order of accepting the ability to be in this study. And then when they died, we were allowed to harvest the implants and send them off for analysis with Dr. Lemon. And then we're able to, we did 5 cases, and that would put the confidence level of the 6th case at a high 95% confidence level. So if anybody wants to prove that these implants are successful long-term, this study nails it down. Okay, as we continue this presentation, I'm going to show you just a few cases. Remember, I've been doing these things since 1988. For most of that time, I actually manufactured the implants for this, so that I probably did 600 or 700 implants over the last years until about 7 to 8 years ago, I discontinued doing it in anticipating of a retirement. Ironically, this is the actually first case that I did in 1988, and we went to the Mission Institute with this patient to Dearborn, Michigan, and we're going to do root forms there at the Mission Institute, but her bone was so thin that Dr. Mish sent her home and instructed that I should go ahead and take an impression and make a subperiosteal implant. Back then, these were made out of Vitalium, and this is the way this implant looked after we placed it. And also, all these years later, 36 years later, this has not changed one bit in this patient's mouth. And she's been healthy, and this tissue's been healthy for all these years. The case was finished with a upper implant supported overdenture, and back then we were doing gold bars with hater clips. Here's this patient 36 years later, a case we did in the late 80s, and she was faithfully coming to my office every 6 months to get this implant checked and her lower teeth cleaned. And this is what happens when patients are compliant and follow through with treatment. Treatment lasted 36 years. She's still alive today and enjoying this implant. Here's initial x-ray, and the bottom right is an x-ray was most recently taken. I'm not sure when that was, but it is in very recent years. And this implant has not changed one bit over the last 36 years. Here's a lady, Anna, who worked for me for a number of years, and she got an implant-supported upper custom Endosteal implant. Here's Anna's x-rays, and the bottom x-ray, I'm not sure when that was taken, but we've lost track of her. But the last we checked, this implant had been in for 16 years. This beautiful lady is Dee, and she's been active with Rotary for 30, as many years as I've known her. She's still very active in it, and is the infectious smile. But that smile is what we gave her. She got her implant 31 years ago, and it was the custom Endosteal upper with the gold bar, and that has not changed one bit in all these years. And she actually follows through on a regular basis, so we know exactly what's happening in her mouth for many, many years. It's very successful. Dee presented with a few snags in the lower and very, very little bone. She had enough bone for rootworms on the lower, but the upper, just no bone whatsoever. So these are the cases that if you don't do implants, it only gets worse over a lifetime to the point where the patients can't even wear a denture. So intercepting these patients with a maxillary custom Endosteal implant, at least for Dee, has worked out for her beautifully for 31 years. So here's a sequence of x-rays. The first one was pre-treatment in 1993, and the treatment 1993, and the most recent x-ray 2020. And this patient has never had any problems with this, no infections. The tissue's always been healthy, but she follows up on a regular basis, and she has very good hygiene, and that's what it takes for these patients. This patient represents probably the majority of my patients because I started doing this in 1988, and most of the patients that need these are in their 60s and 70s, and a couple patients I had two patients that were in their 90s that got these implants. So you can imagine that most of these patients took their implants to the grave. And as I said before, I've been at the same phone number in the same city for over 50 years, and I've been following these cases very closely, probably all the years since 1988. So if there was any problem, they'd look me up and we'd take care of the problem. But amazingly, there's been very few problems over the year. But this lady here, she had her implant 10 years, and this is the last x-ray or last photograph we took before she passed away. You can see from her preliminary x-ray on the left how little bone there is, and then on the right, that's the custom Endosteal implant. It's fully integrated, and for her, it lasted for her whole life. This gentleman has upper and lower implant-supported overdentures, and he did very, very well all these years. I think it was 20 some odd years. So in this case, on the upper left, you can see the snags that we had to take out. And so we got an upper custom implant and then lower root form implants. And these have been in service for over 19 years. This gentleman patient became friends, he and his wife, and have been in the practice for over 25 years. And he got a full upper implant and then lower root form implants. And he is now got Alzheimer's disease, but these implants have been successful all these years for him. And now that he is in the later years, he's still in being able to eat, even though he doesn't remember things. Here are the x-rays of the gentleman we just talked about. with an upper custom and lower root forms. Actually, we had more trouble with his root form implants. We had to do revision on those a couple times, but they all survived, and so they're still in his mouth all these years later. Here's another case: maxillary custom implant and lower root form implants. These have been in service for over 20 years. Here's another. It's called a combination case where the upper is a custom implant and the lower root form implants. But this has been in service for over 20 years. This is like a lot of cases that they're kind of skeptical. So we did, and you can see in the upper left x-ray, we did 2 root forms, and then they want to continue when they see they're successful. And so later we went ahead and did a custom implant on his upper, and this has been in service for over 25 years. And this is a case that came in with failed implants. She had blade implants, which had failed. So we put her into an upper, what we call almost fix, where we have parallel hater bar that swedges into a metal casting in her upper denture, which swedges in. So when it's in, it feels very fixed. This case has been in for 15 years. You can see on your upper left that when you look at the bone on the upper, it's so transparent that you barely get an x-ray of it. And so the lower right shows the custom implant and also a unilateral on the lower. So these were very successful for 15 years. And so this concludes the cases of a spattering of cases that I picked out of hundreds of cases, and they all basically are the same. So it would be boring for me to keep going, but this is pretty much the way it is. And over the years, I've been following these cases. They come in, basically nothing to do. Even the overdentures, I had one that was, I went into another doctor's office and placed it in the late 80s. She was an Iranian lady, and we placed the upper custom implant in an overdenture, and she was in a few months ago, and the only thing she had done is worn through the upper plastic into the hater bar, but the implant and the overdenture had lasted since the late 80s until a couple months ago. So this is what we've been seeing as far as custom endosteal implants, and these type of implants are very successful. It's a shame that this technology might be lost because number one, we don't have as many of these patients anymore. But as far as the technology involved in making these implants, it's gotten very sophisticated. It used to take us months to make these things, and now with three-dimensional printing of the not only the model, but also that we can print the titanium implant itself, we can turn these things around in as much as 3 days. So if we have an emergency, like a fracture of a femur, we could have an implant manufactured within 48 hours, and that would be a custom fit appliance for an orthopedic surgeon. Or some of these fractures that come in for oral surgeons and catastrophic fractures, you do a CAT scan, and then with the modeling, you put everything together and custom make an implant for that. And that way you don't have to bend the wires and the plates that you're doing now, which seems very primitive. And this is the latest technology, three-dimensional printing. Everything is done just a single surgery, and they last for years and years and years, in my opinion. So I think the future is very bright for anybody that wants to get into this part of dentistry.